I'm Maddie, I'm one of the 5th years at Imperial, and today I'm going to be talking you through different types of contraception. So, in terms of contraception, one of the things that comes up a lot is the Pearl Index, and that is an objective measure of if 100 women used that contraceptive for 1 year, how many of them would fall pregnant. And so the Pearl Index can be used to compare different types of contraception with each other, but also can be used to compare, in terms of a particular contraceptive, the difference between its perfect use, so if you use it exactly as you're meant to every single time, or its typical use, which is how most people would tend to use it. So for example, with a pill, missing a few pills each year. So on this table, it shows the difference between the perfect use and the typical use. And you can see that things like the condoms, the cap, the diaphragm, the pills, things you either have to take every day or use every time you have sex, have quite a big difference between their perfect use and typical use. Whereas the long-acting reversible contraceptives tend to have a much more equal perfect use and typical use. So one of the things that's really important to know is how long till they're effective. So the copper IUD and barrier methods are immediately effective in terms of as soon as either the IUD is inserted or as soon as you use barrier methods, they have their contraceptive effect. The progesterone-only pill, you have to have 48 hours of pill cover before it's effective. So for those 48 hours, you have to use barrier methods. And the combined oral contraceptive pill, the implant, the injection, the Mirena, and the Jaydess, for all of these, if you don't start it on the first day of your cycle, then it's 7 days before you can rely on it as a form of contraceptive. So for those 7 days, you should use barrier contraception. So barrier contraception, the condom, it can be female condom or male condom, but the failure rate is very dependent on its usage, as we saw in the first slide. It's best for protection against STIs, and so in PACEs and obviously in real life, you would always advise that people use condoms even if they're using other contraceptive methods. So even if someone has the implant, which as we know has a very low Pearl Index and a very equal Pearl Index for its perfect use and its typical use, you would still recommend that they use condoms because they still need protection against STIs. The cap and the diaphragm are fitted before sex, and they remain in situ for 6 hours after sexual intercourse. So the cervical cap fits over the cervix, as you can see down here in the diagram, and the diaphragm sits between the pubic bone and the sacral curve, and so covers the cervix but also covers essentially the whole upper portion of the vagina. They provide some protection against pelvic inflammatory disease, mainly because they can help prevent the ascension of bacterial infections up through the cervix into the uterus. But they don't really provide much protection against STIs, and they provide less protection against HIV. So again, you'd still recommend people use condoms. In terms of hormonal contraceptives, really the side effects of them are the side effects of the hormones themselves. And in terms of hormonal contraceptives, you have the combined oral contraceptive pill, which has estrogen and progesterone, and then you have combined contraceptive methods, such as the patch and the ring, but you also have progesterone-only methods, so ones that have no estrogen in. So in terms of the side effects, progesterone gives you the PMS-like symptoms, so depression. It can give you some irregular bleeding and spotting. It can also contribute to acne, breast pain, and reduced libido. Now, importantly, weight gain is anecdotally reported with a lot of contraceptives, but weight gain has only been proven to occur with the hormonal injection. So with the progesterone injection, you can have weight gain, and that's really important for questions. They'll say which one has proven weight gain, and it's the injection. And then osteoporosis, again, only really occurs with the injection. With the progesterone injection, you can get a drop in bone density, and that's why it tends to be limited to only using it for a couple of years. The side effects of the estrogens, on the other hand, are things like nausea, headaches, increased vaginal mucus, fluid retention, which anecdotally leads to weight gain, but that isn't a proven link, hypertension, breast tenderness, and again some spotting can occur. So the combined oral contraceptive pill contains an estrogen, which is mostly ethanoestradiol, and a progesterone. And you can take it in two ways. You can either take it the traditional way, which is that you take the pill that contains these two hormones every day for 3 weeks, and then your 4th week you have off, and in that 4th week you have a withdrawal bleed. Or you can take it back to back, so essentially you'd have 3 cycles where you don't have the withdrawal bleeds in between, and then you have a withdrawal bleed. And that's actually what they recommend a lot of the time in endometriosis treatment, to really dampen down the ovarian sort of response. But with that you can get some irregular spotting, because obviously you're going a prolonged time. And the way the combined oral contraceptive pill works is it causes a negative feedback on gonadotrophin release. So it inhibits ovulation. So you have such a high level of estrogen and progesterone all the time that the entire axis is switched off, and therefore you don't get your LH surge and you don't ovulate. As a side effect, essentially, it also thins the endometrium and thickens cervical mucus. So the side effects of the combined pill can be split into good and bad side effects. So you don't get pregnant, you get less painful, lighter periods. I've put periods in inverted commas because it's not technically a period, it's a withdrawal bleed, but it regulates your bleeding, it makes it less painful and lighter, and for that reason people can be on the pill to make either their periods more regular or to make them less painful. And the pill could also give you some protection against ovarian, bowel and endometrial cancer. But there are some negative side effects of the combined pill, and a lot of these are really the contraindications. So it can increase your risk of VTE, of MI, of a migraine, of hypertension, and it can increase your risk of liver, cervical and breast cancer. So it's protective against ovarian, bowel and endometrial cancer, but it increases your risk of liver, cervical and breast cancer. And you'll see I've put don't get pregnant in both good and bad side effects, and that's because people can be on the combined oral contraceptive pill for a lot of reasons that aren't its contraceptive use. So people might have very painful periods, people might have very heavy periods and not want the Mirena coil inserted and things like that. And so actually the combined pill can be used for lots of reasons, and you need to discuss people's plans for family, people's plans for contraception with them if you're suggesting the combined oral contraceptive pill for a reason that isn't its contraceptive use. Because it could be that they're planning to get pregnant, it could be that they don't want to get pregnant. So it could be either a good or bad side effect. So the contraindications for the combined pill. So there are some absolute contraindications where you can never, ever, ever prescribe it. And that would be these. So any VTE in the past, it doesn't matter what the circumstances were, if they've had any VTE in the past, they can't have the combined oral contraceptive pill. And likewise, anything that already increases their risk of having a VTE, so any thrombogenic mutations, they really shouldn't be on the pill. If they have a migraine specifically with aura, they can't have the combined pill. If it's without, then it's a relative contraindication. If they have active breast or endometrial cancer, if they are pregnant, they cannot have the pill. This is a recent change to the guidelines, so your textbooks might be out of date with this one, I know mine was. If they're breastfeeding up to 6 weeks postpartum, they can't take the combined oral contraceptive pill. It used to be an absolute contraindication of 6 months. Now it's 6 weeks, and then up to 6 months is a relative contraindication. Smokers, specifically if they are over 35 and smoking more than 15 a day, they can't have the combined oral contraceptive pill, and that's both of those. They need to be both over 35 and smoking more than 15 a day. If their BMI is over 40, if they've got diabetes with complications, and if they've got liver failure, because obviously that have implications over the metabolism of the pill. Now, the relative contraindications are essentially everything that's an absolute contraindication, but slightly less bad. So all smokers, if someone's got chronic inflammatory disease, renal impairment, diabetes, if they're over 40, if they've got a predisposition towards having a breast cancer, if they're immobile for whatever reason, as I said, 6 months postpartum, and if their BMI is 35 to 40, so 40 was the absolute contraindication, 35 is a relative contraindication. Now, the progesterone-only pill. It primarily works by thickening cervical mucus. So it's a low-dose progesterone, and there are two main types. You've got most of the mini pills, and the most predominant one is Mirena, and that has a 3-hour window in which you have to take it. So you have to take it within 3 hours of the same time every day. And they say in 50% of people inhibits ovulation, but really its primary action is that it thickens cervical mucus. And Cerazette is the newer progesterone-only pill, which has a 12-hour window, and it seems to inhibit ovulation a lot more, but again, the main way it works is by thickening cervical mucus. And so it makes the cervical mucus hostile to sperm, so sperm can't reach the egg. And the main thing to remember is it can be used where the combined oral contraceptive can't. So any of those absolute or relative contraindications, they can take the progesterone-only pill. But irregular spotting is more common, and the way you take it is you just take it continuously. You take it every single day of the year, around the same time, within 3 hours or 12 hours, depending on which one you take. And because of that, you can get some breakthrough bleeding. The contraceptive patch. So each patch lasts a week. You have 3 weeks of patches and then a week off. So you can already tell it sounds very much like the combined oral contraceptive pill, but it's on a patch form. And it is a combined hormone patch. It inhibits ovulation just like the pill does. But the important thing is it's still effective even if you have a GI upset. So it's sort of predominantly marketed at people who have inflammatory bowel disease, stuff like that, where they have a lot of diarrhea, and so you can't really rely on the absorption of the pill because you can't rely on its GI absorption. The patch doesn't need GI absorption, and it bypasses the first pass metabolism. The vaginal ring is again combined hormones. You insert it into the vagina, it stays in there for 3 weeks, and you remove it for a week. You have a new ring every month. It's the same as the combined pill, but it has less systemic estrogen and progesterone, so because it acts locally, and so really it's for people who have more side effects but still want the combined hormones. Now, really importantly, when not to use hormonal methods at all. So we've gone through when you can't use particularly the combined oral contraceptive pill. All women on an enzyme-inducing drug should be offered a reliable contraceptive method. And the reliable contraceptive method is either a copper IUD, a Mirena IUS, or a progesterone injection. So the enzyme-inducing drugs are epilepsy drugs, so phenytoin, carbamazepine, barbiturates, etc. A niche side point is if they're on lamotrigine, you can give them the progesterone-only pill, but that's really niche. But basically, it's phenytoin, carbamazepine, barbiturates. If you see in a question that a young lady has epilepsy and wants to go on any hormonal methods, you'd suggest they have either the copper IUD or the Mirena or the progesterone injection. Also, rifampicin, the antibiotic, can have an effect on hormonal pills, and so you'd offer again the copper IUD, Mirena IUS, or progesterone injection. And if there's a really strong family history of breast cancer, or there's a proven BRCA mutation in the family, the copper coil is the safest. So you offer the copper IUD, no hormonal methods. Now, long-acting reversible contraceptives. First, the implant. It's a subdermal implant. It goes in the arm. It lasts for 3 years. And it's progesterone, and it inhibits ovulation and thickens cervical mucus. you get the progesterone side effects. You can get some irregular bleeding in the first year, but then in the vast majority of women, it fades into amenorrhea for the next 2. And it's a small dose of systemic progesterones released every day from this implant, but it's not actually a massive dose all at once like the injection is, so you don't have a drop in bone density. And removal is easy. And the key point with the implant, remember, is that after you remove it, you rapidly resume being fertile again. So as soon as those 3 years are up and it's taken out, if you don't put a new one in, you could get pregnant in the next cycle. And it is safe whilst breastfeeding. So where the combined oral contraceptive pill is an absolute contraindication for 6 weeks postpartum, and then relative contraindication for 6 months if breastfeeding, this is safe whilst breastfeeding. Depot-provera. Now this is the brand name for the progesterone injection. It's an IM injection every 3 months. There are some variations on that with different forms of injection there are. It inhibits ovulation and thickens cervical mucus. Again, it's a progesterone, so you often get irregular bleeding in the first few weeks, and then you'd get amenorrhea, just like the implant. But as we've already talked about, this is the one that gets the side effects. So you have the proven weight gain and the osteoporosis risk. You can also have a risk of prolonged amenorrhea for up to a year afterwards. So it's really not for people who are planning on getting pregnant at some point in the next few months, because A, you can't just take it out. So the implant, the IUS, the IUD, when you want to get pregnant, you can just remove it and you'll rapidly resume fertility. You have to wait out 3 months with this because it's in your system. And then even once it's out of your system, you might be amenorrheic for up to a year afterwards. It also can decrease your bone density. So there's a limit. Normally they'd say don't be on it for longer than about 2 years. And again, proven weight gain. Now the Mirena and the Jaydess IUS, so intrauterine system. It's most commonly the Mirena coil. It's a hormone IUD, so intrauterine device. So all IUSs are IUDs. So the system is sort of the delivery of the hormone, if you think of it that way. And the device is just it being something in your uterus. So all intrauterine systems are intrauterine devices, but not all intrauterine devices are intrauterine systems. So the intrauterine system is a hormone intrauterine device. It is local progesterones, and so it's least likely to have side effects out of all of the progesterone devices. The Jaydess is smaller and it lasts for 3 years. The Mirena lasts for 5 years. And it thins the endometrial lining. It's used a lot for people with particularly heavy periods. It really thins down the endometrial lining and thickens cervical mucus. And because of that, the embryo cannot implant. And you can get some irregular light bleeding with it. The copper IUD. Now remember, IUD just means something in the uterus. So an IUD can either be a copper IUD or an intrauterine system. So the copper IUD. Copper is toxic to sperm. And it also prevents implantation of the embryo. But the really important thing is, unlike most of the other hormonal or most of the other sort of contraceptives, the copper IUD makes periods heavier. It makes them heavier and more painful. But it's also the most effective form of emergency contraception there is. It's effective for up to 5 days after unprotected sex, or up to 5 days after the ovulation date, because it prevents the implantation of the embryo. Now, the absolute contraindications for an intrauterine device. If you have endometrial or cervical cancer, If you have undiagnosed vaginal bleeding, because that could be an endometrial or cervical cancer. If you have active infection, because the infection can sort of implant onto the device. If you have current breast cancer, but that's particularly for the Mirena, because as we've talked about, in terms of breast cancer, actually the one form of contraception you would want to think about using is the copper coil. And if you're pregnant, for obvious reasons. Now, the relative contraindications for the intrauterine devices are if they've had a previous ectopic pregnancy, and we'll talk about that in a second, if they're immunocompromised, again because of this risk of infecting of the device, and if they've already got excessive menstrual loss, and again, this is where there's a split. Excessive menstrual bleeding would be an indication for giving someone a Mirena coil, and would be a contraindication for giving someone a copper coil, because Mirenas make your periods much lighter, copper coils make your periods much heavier. Now, the risks of having an intrauterine device: perforation, when they're put in, you could perforate the uterus. Expulsion, so they could, potentially if they're not in the right place, they could be expelled somewhere else, or you can expel them vaginally. And with the intrauterine devices, you are less likely to get pregnant. It is a very effective form of contraception. The Pearl Index, I think, is 0.1 for the Mirena. But the really important thing to remember is that you have an increased risk if you get pregnant on an IUD. You are more likely for that pregnancy to be an ectopic pregnancy, because it can't implant in the uterus. That's what the intrauterine devices do. They stop implantation, and so it's more likely to then implant into the fallopian tubes until you'll have an ectopic pregnancy if you get pregnant on an intrauterine device. So, some questions. Mary has just started the combined oral contraceptive pill. She started it on day 3 of her cycle. What do you advise? So the correct answer is B. She needs to use condoms until she's got to day 7, and that's because if she'd started it on day 1, the first week would be enough to switch off the ovarian function and she'd be unlikely to ovulate. She started on day 3, so she doesn't necessarily have the full 7 days of protection before her ovulation date, so you would recommend that she should use condoms until day 7, because it takes 7 days for the combined oral contraceptive pill to be effective. If you need more explanation on that, it's something I go into a lot on the Miss Pill Rules tutorial. Question 2. So can she have the combined oral contraceptive pill? No. It's a really long history, and I might have interrupted you before you finished reading it, but the really key point of this is it doesn't matter the circumstances of the VTE. If she's had a VTE in the past, in no circumstances can she be given the combined oral contraceptive pill. It's an absolute contraindication. So who cannot have the combined pill out of this list? So the correct answer is the 25-year-old breastfeeding at 5 weeks postpartum. So that's because the combined oral contraceptive pill is absolutely contraindicated until 6 weeks postpartum. So the first one, the 39-year-old smoker of 10 a day, is incorrect because that's only a relative contraindication. In order for that to be an absolute contraindication, they'd have to be smoking more than 15 a day as someone over 35 years old. The second one is incorrect because, again, BMI 35 to 40 is a relative contraindication. A BMI over 40 is an absolute contraindication. An ectopic pregnancy has no relation to the combined oral contraceptive pill. You would think about it in terms of an intrauterine system or an intrauterine device, because they can increase your risk of having an ectopic pregnancy if you get pregnant on them. And then a 30-year-old with migraines but without an aura, if they had an aura, it would be an absolute contraindication. Because they don't have an aura, it's not. So, in summary, there are lots of contraindications to the combined oral contraceptive pill, and I think it would come up a lot in questions. When the combined oral contraceptive pill can't be used, use the progesterone-only pill. The long-acting reversible contraceptives are really favoured because they have equal, perfect, and typical use. But there are some risks alongside those, and you need to learn those. And if hormones can't be used or relied upon, so if they can't be used, say, because of family history of breast cancer, or they can't be relied upon because someone's on epilepsy drugs, you have to use the copper coil. I really hope that was helpful, and please subscribe to the channel to stay up to date with the latest tutorials.